A warm good evening, everybody. I hope you can hear me and clear me. You can hear and listen to me clearly. Just let us know if the audio video is good. Good evening, everybody. Good evening, Mukul, Tracy, Atul, Anisul, Dr. Anonymous, Nisha, Priyadarshini. So this is a quick revision session that we are planning. We have been doing 30 most important MCQs. These will not be a lot of, difficult topics and all, but relevant topics which are high yield and expected in your exams. So we'll be doing these sessions for different subjects and on the YouTube channel of Arise Medical Academy, and I hope this helps you in your exam preparation. So without waiting much, we'll get started with the topic. Let us look at, and I want you all to be actively involved with the discussion, guys. Okay, so as the question, these are all MCQ based discussions that we'll do, and I'll teach the relevant high yield points throughout the discussion. So look at the first question. Look at the first question. A 12-year-old child was admitted to the hospital with fever. Chest radiograph was given below. What is the correct match? What is the correct answer for this? Is it a snowman heart of total anomalous pulmonary venous communication, boot-shaped heart, egg-on string appearance of transposition of great arteries, or box-shaped heart? So everybody is doing it correctly. So very nice. This is boot-shaped heart or tetralogy of Fallot. What do we also call this? What is the other name of all of this? 𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 you can see a concave pulmonary area because of the pulmonary stenosis that occurs in tetralogy of Fallot. Remember, in tetralogy of Fallot, you have subpulmonic stenosis, right? The subpulmonic stenosis. So because of the subpulmonic stenosis, you have a concave pulmonary area. And you also have an upward cardiac apex. Because of the right ventricular hypertrophy, you'll having the 𝗲𝗵𝗻𝗆 form. The 𝗲𝗵𝗻𝗆 is formed by the right ventricular hypertrophy, and there is a upward cardiac apex. There is upward cardiac apex, right? So this is what is called as boot-shaped heart. Boot-shaped heart, feature of tetralogy of Fallot. So the first one is tetralogy of Fallot. And are the other options correct? Snowman heart is seen in supracardiac type of 𝗖𝗵𝗄𝗃, right? So this is supracardiac type of 𝗖𝗵𝗄𝗃. Egg-on string is seen in transposition of great arteries, that is also correct. Box-shaped heart is Epstein's anomaly. Let us look at the images. So this is how we have a concave pulmonary area, upward cardiac apex. This is tetralogy of Fallot. Tetralogy of Fallot. The 𝗧𝗏𝗃𝗃. Remember the other name also of boot-shaped heart, 𝗧𝗏𝗃𝗃. 𝗧𝗏𝗃𝗃, that is boot-shaped heart. And what is the second one? What if this radiograph is given and a cyanotic heart disease patient, newborn with cyanosis, and this image is given? What is your answer here? Here you are seeing a narrow superior mediastinum. This is called as egg on string appearance. Egg on string appearance. This is feature of transposition of great arteries. Transposition of great arteries. So in transposition of great arteries, when the pulmonary artery comes from the left ventricle and the aorta, the pulmonary artery comes from the left ventricle and the aorta comes anteriorly and to the right. So when you have this kind of arrangement, it appears like a narrow superior mediastinum, that is the string, and the heart appears like the egg. So that is called egg on string appearance. There is a narrow superior mediastinum, egg on string appearance, transposition of great arteries. And look at this image. What do you see here? Here you can see the right heart border going more towards right. You can see this is the right heart border. The right heart border is more towards the right. That is suggestive of right atrial enlargement. And look at the left heart border. Left heart border is okay. Left heart border is normal, but the right heart border is more towards right, giving the appearance of a box-shaped heart. Box-shaped heart. So box-shaped heart. This is classic of Epstein's anomaly. Epstein's anomaly, right? In Epstein's anomaly, what is the basic problem in Epstein's anomaly? What is the basic problem in Epstein's anomaly? What do we have in Epstein's anomaly? You have a low-lying tricuspid wall, right? So low-lying tricuspid wall. So when your tricuspid wall is low-lying, what will happen? You will have a large right atrium and a small right ventricle because the tricuspid wall is low-lying. So please remember, low-lying tricuspid wall. In Epstein's anomaly, you have right atrium which is enlarged and a small right ventricle. There is atrialization of the ventricle. Because of the low-lying tricuspid wall, part of the ventricle becomes atria. Part of the ventricle becomes atria, low-lying tricuspid wall. This is box-shaped heart, right? Epstein's anomaly, atrialization of right ventricle. large right atrium and small right ventricle. This is 𝗵𝐶 anomaly, occurs due to lithium toxicity, right? So lithium toxicity in the mother produces 𝗵𝐶 anomaly. Please understand how to identify the radiograph. And in which condition do you see such pericardial calcification, guys? Do you remember? Where do you see pericardial calcification? Pericardial calcifications. Pericardial calcifications, this is feature of constrictive pericarditis. Constrictive pericarditis. And what is this appearance called? What is this appearance called? This is called as egg in cup appearance. Egg in cup. So do not confuse with egg on string appearance. Egg on string appearance with transposition of great arteries with egg in cup appearance. Remember C for C. Egg in cup appearance is constrictive pericarditis. Constrictive pericarditis, the pericardial calcification. And this is classic. This is your previous FMG question. You had this image in the exam. This is snowman appearance, right? Snowman or cottage loaf or classic figure of 8 appearance of heart. This is supracardiac 𝗙𝗵𝐵𝐶. Supracardiac 𝗙𝗵𝐵𝐶. Can I ask you, where do you see figure of 8 appearance of brain? In which condition? Anybody? Fastly. In which condition do you see figure of 8 appearance of the brain? So figure of 8 appearance of the brain. Fast. Okay, we have to cover a lot of questions. Fastly, if you can remember, figure of 8 appearance of the brain. This is seen in 𝗬𝗏𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 Listen, 𝗬𝗏𝗃𝗃𝗃𝗃𝗃 area, absence of gyration. So you have only sylvian fissure, rudimentary sylvian fissure, and no gyration. No gyration. So egg area is called as 𝗬𝗏𝗃𝗃𝗃. You have this figure of 8 appearance of the brain. Figure of 8 appearance of the cella 𝗙𝗃𝗃𝗃. So at the cella, the dorsum cella, you have a mass which grows in the dorsum cella, then constricts at the dorsum cella and comes back, giving a figure of 8 appearance. This is pituitary macroadenoma. Pituitary macroadenoma. So remember these 3 figure of 8 appearances. Figure of 8 appearance is also a tested topic. Figure of 8 appearance of the heart is supracardiac type of 𝗙𝗵𝐵𝐶. Only the supracardiac type. This forms the figure of 8 appearance of heart. Total anomalous pulmonary venous communication. Figure of 8 appearance of the brain is 𝗬𝗏𝗃𝗃𝗃𝗃. What is meant by 𝗬𝗏𝗃𝗃𝗃𝗃? Egg area, absence of gyration of the brain. Egg area. This is figure of 8 appearance of the brain. Figure of 8 appearance at the cella, that is pituitary macroadenoma. Let's go to the next one. Let's look at the next one. Easy one. Good evening, Santosh, and good evening, everybody. Let's answer the second one here. A radiograph is obtained from a child with skeletal abnormality. What is the name of the angle being measured here? What do you think is this angle being measured here? This is easy, very good. 𝗚𝗏𝗃𝗃𝗃. This is 𝗏𝗃 angle. 𝗏𝗃 angle. So this 𝗏𝗃 angle, if it is more than 10 degrees, it is suggestive of scoliosis, right? So 𝗏𝗃 angle is for scoliosis. Now, what is the other angles that we have? Can anybody tell me where do we measure the Bowler's angle? Anybody? Bowler's angle? Anybody? Bowler's angle? Do you remember any of your orthopedics classes? Bowler's angle. In your orthopedics, you study this. Very good, Neelam. Very good, Neelam. Calcaneal fracture. So calcaneal fractures, right? Calcaneum, fracture of the calcaneum will produce decrease in the Bowler's angle. The Bowler's angle is reduced in calcaneal fracture. Kite's angle, anybody? Where do we measure Kite's angle? Kite's angle. Kite's angle. Very good. Kite's angle is CTEV, congenital talipes equinovarus. Congenital talipes equinovarus. Bowman's angle. Bowman angle. Bowman angle. Do you remember Bowman's angle? Bowman's angle. This is for supracondylar fracture. The reduction in supracondylar fracture of humerus. To look for the reduction, to see whether there is proper reduction of the supracondylar fracture of humerus, we go for Bowman's angle. Let's look at these angles quickly. So, from the upper end of the vertebra and the lower end vertebra, when we measure an angle or we draw tangents across it and measure the angle, both of them, this is 𝗏𝗃 angle. Either you intersect them or you draw 90 degrees perpendiculars to it, both of them are the same, that is 𝗏𝗃 angle. And 𝗏𝗃 angle is measured for scoliosis. A 𝗏𝗃 angle more than 10 degrees is called as scoliosis, a 𝗏𝗃's angle more than 10 degrees. Between 10 to 20 is mild, between 20 to 40 is moderate, and more than 40 is severe scoliosis. Just remember, a 𝗏𝗃's angle more than 10 degrees is suggestive of scoliosis. It is for scoliosis. Now, coming to Wöhler's angle and 𝗬𝒃 angle. Now, Wöhler's angle is this area, this white dotted line, this is your Wöhler's angle. And this yellow lines, this correspond to 𝗬𝒃 angle. 𝗬𝒃 angle. So Wöhler's angle is from when the anterior articular facet of the calcaneum and the posterior articular facet of calcaneum, when we draw tangents and when you intersect them, you get an angle that is called as Wöhler's angle. So whenever we have fracture of the calcaneus, the Wöhler's angle reduces and the 𝗬𝒃 angle increases. Wöhler's angle reduces less than 20 degrees in calcaneal fracture, and 𝗬𝒃 angle increases in calcaneal fracture. Just remember, these two angles are measured for calcaneal fractures, Wöhler's angle and 𝗬𝒃 angle. In calcaneal fracture, the Wöhler's angle will reduce and 𝗬𝒃 angle will increase. Okay, this is calcaneal fracture. Coming to the 𝗘𝗏's angle, the talocalcaneal angle. So between the mid-tarsal line and the mid-calcaneal line, you measure this angle. This is called as a talocalcaneal angle or the 𝗘𝗏's angle, right? 𝗘𝗏's angle. So whenever you have a varus deformity, so this is how the normal 𝗘𝗏's angle is. But when we have a varus deformity, the 𝗘𝗏's angle is reduced. So 𝗘𝗏's angle is reduced in case of CTV. So remember, 𝗘𝗏 has this thing TE. Remember, CTEV. So 𝗘𝗏's angle and 𝗘𝗏's view is used for what? CTV, congenital talipes equinovarus. So once again, let's come back to the question. 𝗏𝗏's angle. A 𝗏𝗏's angle more than 10 degrees is suggestive of scoliosis. Decrease Wöhler's angle and increase in 𝗬𝒃 angle is suggestive of calcaneal fracture. 𝗘𝗏's angle is for CTV. Now let's look at what is Bowman's angle. Now Bowman's angle, so you look at this. This is the angle through the mid shaft of the humerus, and this is along the capitulum, the lateral condyle of the humerus, the capitulum, the lateral condyle of the humerus. So this humerocapital angle, the humerocapital angle, so along the physeal plate of the capitulum and the shaft of the humerus, you measure this angle. This is called as Bowman's angle. And when we have a varus deformity, so normally the Bowman's angle is around 70 to 81 degrees. But whenever there is varus deformity, the cubitus varus or malunited supracondylar fracture of humerus, the malunited supracondylar fracture, above the condyle, supracondylar fracture of humerus. This produces Gunstock deformity, right? Gunstock deformity, the cubitus varus. So when we have cubitus varus, the Bowman's angles will increase. So increase in Bowman's angle is suggestive of malunited supracondylar fracture or cubitus varus. So Bowman's angle is for supracondylar fracture of humerus. So I hope you are clear with these angles. Let's come to the next question. Now let's look at the next question. Try to answer this. On 5th postoperative day following lap cholecystectomy, a patient presented with pain abdomen. On ultrasound, a 5x5 collection is seen in the Morrison's pouch. A possibility of biliary leak is suspected. What is the most sensitive investigation to detect bile leak? So there is a cholecystectomy patient with a collection in the Morrison's pouch and bile leak is suspected. What is the most sensitive investigation to detect bile leak? What is your answer? Very good, right? To detect the biliary leak, you go for HIDA scan. Please remember, HIDA scan is the most sensitive investigation for bile leak. But HIDA scan or nuclear scans, they are having poor anatomical detail. It does not show you the anatomical detail. It only tells you that the collection is bile. Okay, the tracer activity in the area will tell you that is bile that is coming there because of the HIDA area in the HIDA uptake in that area. To know the anatomical site of bile leak, the gold standard for anatomical site of bile leak, to detect anatomical site. So be careful on the day of exam, look at the question carefully. To detect anatomical site of bile leak, go for ERCP. The gold standard for detecting anatomical site of bile leak is ERCP. The sensitive investigation for bile leak is HIDA scan. What about 𝗬𝗲𝗵𝗵 scan? For which condition do you use 𝗬𝗲𝗵𝗵 scan? You heard of 𝗬𝗲𝗵𝗵 scan for which condition? Can you tell me? For which condition did you use 𝗬𝗲𝗵𝗵 scan? 𝗬𝗲𝗵𝗵 scan is for localization of parathyroid adenoma. So for parathyroid adenoma, we use 𝗬𝗲𝗵𝗵 scan. And for what we use MIBG scan? Anybody? Where do we use MIBG scan for? MIBG scan is for MIBG scan. Looking at your answers, MIBG scan. Very good, Anishul. This is for pheochromocytoma. Pheochromocytoma. So remember these important ones. This is for some important nuclear scans that we have, right? For the 𝗬𝗲𝗵𝗵 scan for parathyroid adenoma and MIBG scan for pheochromocytoma. Let's come to the next one. Let me see how many of you will answer this correctly. Ultrasound is least useful in. Ultrasound is least useful in retroperitoneal hematoma, pneumothorax, hemoperitoneum, or pericardial effusion. Which one would you choose? Ultrasound is least useful in. Bond says pneumothorax. Other people are choosing, I see A and B in the options. Anything else you would like to? Please remember, pneumothorax, you must have studied this in your 𝗬𝗏, will show you stratosphere sign or barcode sign on 𝗬𝗏, right? That is ultrasound, right? On ultrasound. So we can detect pneumothorax on 𝗬𝗏, right? So it's better than X-ray to look at pneumothorax. Ultrasound is very useful to look at pneumothorax in your patients. And we can see hemoperitoneum, the collections, right? So pericardial effusions by ultrasound. But this is not useful for retroperitoneal hematoma. Retroperitoneal hematoma, the investigation of choice is contrast enhanced CT scan, right? Contrast enhanced CT scan. All the other ones can be detected by ultrasound, that is sonography. Remember, FAST, which uses the 4 views that we have. This is for pericardial collections, pericardial collection, and hemoperitoneum. And what is the difference between FAST and 𝗬𝗏? What is 𝗬𝗏 having? Along with the same 4 FAST views, that is, it can detect pericardial collection and hemoperitoneum. This can also look at pneumothorax. So that is the difference between FAST and 𝗬𝗏. Focused assessment with sonography for trauma or extended focused assessment with sonography for trauma. You can see pericardial collection, hemoperitoneum, and pneumothorax on ultrasound. But for retroperitoneal hematoma, investigation of choice is CECD. So the first view that we take in FAST is your 𝗬𝗲𝗹𝗺 view, and this is also called subcostal view. This is for pericardial collection. We tilt the probe upward to see the collection around the heart. The second and the most sensitive for hemoperitoneum. The Morrison's pouch is the most inferior portion of the peritoneum, the hepatorenal space between the liver and the kidney. This area, the Morrison's pouch, is the most inferior portion of the peritoneum in a supine patient. So any hemoperitoneum will first collect in this area. So the most sensitive for hemoperitoneum is the right upper quadrant or the right lumbar view. Remember, the first view is different, most sensitive view is different. The first view done during FAST or 𝗬𝗏 is your 𝗬𝗲𝗹𝗺 view, whereas the most sensitive for hemoperitoneum is the right lumbar view. We also have the left lumbar and also the pelvic view. These are the 4 views that we take in FAST. In 𝗬𝗏, along with this, we also put the probe in the right and left anterior-thoracic view. So this is what is 𝗬𝗏. 𝗬𝗏 we use along with 4 FAST views. We also use right and left anterior-thoracic views, right? So anterior-thoracic views to look at pneumothorax. So there is a difference between FAST and 𝗬𝗏. Let's come to the next question. Let's look at this question. Question number 5. Identify the MRI sequence. Is it T1 weighted imaging? Is it susceptible weighted imaging, or a T2 weighted image, or a diffusion weighted image? What do you think is this? What do you think is this? Quickly, can you identify the sequence of MRI here? Is it T1 weighted MRI, T2 weighted MRI, susceptible weighted image, or a diffusion weighted image? Now, please look at the image carefully. Okay, so look at the image carefully. Can you see the bone or the subcutaneous fat? Are you able to see any bone or subcutaneous fat? There is no surrounding soft tissue. No surrounding soft tissue or bone. So such a sequence of MRI where you don't see the surrounding soft tissue, this is a diffusion weighted imaging. Diffusion weighted imaging. And what do you see on this sequence? This is showing a light bulb appearance, right? A shiny bright appearance, a bright signal in the right MCA territory. So light bulb appearance, you're seeing a light bulb appearance on right MCA territory. And what does light bulb appearance suggest? This is suggestive of acute infarction. This is acute infarct. The most sensitive investigation to look at acute infarct is a diffusion weighted MRI. So this is a classic diffusion weighted MRI. So the diffusion weighted MRI will not show you the surrounding soft tissue. Let me quickly go through the sequences of MRI for your exam. So please look here. If the bone is white, and the subcutaneous fat is black, if the bone is white and the fat is black, this is CT scan. But look at the subcutaneous fat. If the fat is white and the bone is black. So if the bone is black and the subcutaneous fat is white. Look here also, you can see it here. So if the bone is black and the subcutaneous fat is white, this is MRI. So the difference between CT and MRI is, in CT the bone is white and the fat is black. In MRI the bone is black and the subcutaneous fat, the skin will be first and then bone will be there. So skin will be white and the bone will be black. So this is MRI. And how do you know which is T1 and T2? Look at the gray matter and the white matter. So if you look at the gray matter and the white matter, look at the outer gray matter. The gray matter is gray and the white matter is white. They go by their name, right? In a T1 weighted image. So in a T1 weighted image, you're having the gray matter is gray. The gray matter is gray. The white matter is white. They are going by their name. White matter is white. And look at the CSF signal. Look at the CSF signal. The CSF is dark or fluid is dark. CSF or fluid is dark. This is T1 weighted image. In a T2 weighted image, the opposite is correct. Look at the outer gray matter and the white matter. Look at the fluid. So if you see the gray matter is white. The white matter is black. And the CSF or fluid is white. We all study this. Water is white. Water is white on T2. We call this World War II. World War II. Water is white on T2. The fluid in the ventricle, fluid in the sulcal spaces, fluid in the sylvian fissure, right? Sulcal spaces, interhemispheric area. All of this fluid is white. Water is white on T2. But you can see the surrounding soft tissue, right? You can see the surrounding soft tissue. But if you have a sequence of MRI where you don't see the surrounding soft tissue, that is what is a diffusion weighted imaging. Diffusion weighted imaging. Now you can see here. Can you see any soft tissue here? No, right? So this is a classic diffusion weighted imaging. Diffusion weighted imaging. And what is it showing? This is showing a left MCA infarction. Left MCA infarct, a light bulb appearance in the left MCA territory. And if the vessels are jet black and you are seeing these blooming artifacts, these are called, blooming artifacts, dark areas that you are seeing. So these are called as blooming artifacts. Blooming artifacts. So if you see jet black vessels with blooming artifacts, this is susceptibility weighted imaging. Susceptibility weighted imaging. Susceptibility weighted imaging. So around calcifications, hemosiderin, microhemorrhages, you see this blooming artifacts. Around microhemorrhages, hemosiderin, and calcification, you see this blooming artifacts. When you see blooming artifacts, that is susceptibility weighted MRI. And what is this sequence? What do you think is this sequence that I am showing you here? I can see the surrounding tissue, I can see the fat, I can see the bone, and I'm seeing the sequence here. Can you ask me what, can you tell me which sequence is this? Can you try? Which sequence is this? Is it T1, T2 or any other sequence that is coming to your mind? Can you try which sequence is there? Very good, Anishu. So you're seeing that this is gray matter is white and white matter is black. Same as T2, same as T2. Gray is white and white is black. But look at the fluid is suppressed, the fluid is dark. So if your white matter is also black and the fluid, the CSF is also black, both of them are black, right? Both of them are black. This is a FLAIR MRI. If this is a FLAIR MRI. So if I show you T1, T2, if I show you T1, T2, the white matter and the CSF are opposite signal. So if you look at the white matter in T1, the white matter is white and the CSF is dark. But if I look at T2, the white matter is black and the CSF is white. They are never the same color. They are never the same color. If your white matter is also black and the CSF is also black, this is called FLAIR. What is FLAIR? It is fluid attenuation, inversion recovery. Fluid attenuation, inversion recovery. It is same as T2. Same as T2. Gray matter is white, white matter is black. Same as T2. But there is fluid suppression. Fluid suppression. So fluid suppressing sequence. Fluid is dark. Same as T2. Gray matter is white, white matter is black. Same as T2 with fluid suppression. This is called as FLAIR MRI. And what do you want to call this sequence, guys? What do you want to call this sequence? What is this sequence of MRI? Where you see all these tracts in colorful areas. What is this thing? This area where the colorful tracts are seen, this is diffusion tensor imaging. Diffusion tensor imaging. Also called as DTI, right? Diffusion tensor imaging or tractography to look at white matter tracts. So this is tractography or diffusion tensor imaging. So just identify the sequences properly, right? I hope you can get this correct on exam. Which is CT, which is T1, which is T2, right? Which is diffusion weighted imaging, which is susceptible weighted imaging, how to identify FLAIR and how to identify the diffusion tensor imaging. Quickly, let me know if you're okay. Can I go to the next one? Let's go to the next one. Are you guys okay so far? Can we move to the next one? Quickly tell me if you're comfortable. Let's go to the next one. Okay, try to answer this thing. Try to answer this. Chalo. A 3-year-old child, while playing, developed sudden onset of breathlessness and wheezing. On auscultation, significantly decreased breath sounds were seen in the right lung. Chest radiograph shows diffusely opaque right hemithorax. What is the probable diagnosis? Okay, what is the probable diagnosis? Very good, very good. Everybody is answering this correctly. So 3-year-old child, sudden onset of breathlessness, decreased breath sounds on right side and right opaque hemithorax. All of this is going towards foreign body aspiration. Do remember, 2-year or 3-year-old child, sudden onset of respiratory distress, right? And having either a opaque hemithorax or a lucent hemithorax. Either in the question they say there is opaque hemithorax or lucent hemithorax. All of this should make you think of foreign body. Right? So this age group is notorious to have this foreign body aspirations. Sudden onset of respiratory distress. Radiograph showing either a opaque hemithorax or a lucent hemithorax. So if you see, one hemithorax is completely opaque. So if the foreign body is causing complete obstruction of the bronchus, there could be collapse of the lung and opaque hemithorax. Or if the foreign body is causing a ball-valve mechanism, the air is about to come in but not allowed to go out. You will see air trapping in expiratory phlegm. Leading to lucent hemithorax. So either a opaque hemithorax or a lucent hemithorax. You see either opaque hemithorax or a lucent hemithorax in a child of 2 to 3 year age group with sudden onset of respiratory distress. Please suspect foreign body. Right? So keep this in mind. Okay, opaque hemithorax or lucent hemithorax, both of them are suggestive of foreign body. So you will see air trapping in the expiratory phlegm in cases of foreign body, and you see a lucent hemithorax. Next. Now, a child presented with mild abdominal discomfort with intermittent abdominal pain. There is no other symptom. Radiograph was given below. What is the likely diagnosis? What do you think is the patient's diagnosis here? Yes, Shubham, we'll be doing it for most other subjects also. Okay, it will be a regular thing. Do attend. It's like simple in 30 important questions that you can, revise with. So what do you think this is? Okay, I'm getting most of them are answering it correctly. This is 𝗏𝗏𝗃 hernia. You're seeing the bowel loops of the abdomen herniating to the left hemithorax. This is 𝗏𝗏𝗃 hernia. So it is left posterolateral, This is most common type of congenital diaphragmatic hernia. If it was right anteromedial on the right hemithorax and on the anteromedial aspect, that would be Morgagni, but this is on the left hemithorax. This is 𝗏𝗏𝗃 hernia. 𝗏𝗏𝗃 hernia sometimes can be associated with left lung hypoplasia also, because the bowel loops are entering into the left hemithorax. They'll cause left lung hypoplasia. So this is associated with left lung hypoplasia. Now, gastric volvulus is characterized by Bouchard's triad, right? The retching without vomiting, epigastric pain, right, and inability to pass the nasogastric tube, right? All this gastric volvulus will have that Bouchard's triad. What about diaphragmatic eventration? Now, diaphragmatic eventration is a contour abnormality of the diaphragm, where you see a hump. It's a congenital, usually a congenital one, or could be acquired due to nerve damage, like phrenic nerve palsy, phrenic nerve injury, or stuff like that. So you see a small contour abnormality that you see in the diaphragm. This is diaphragmatic eventration, usually a congenital problem. This is diaphragmatic eventration. But if you are having a history of trauma, right, and you see usually the left hemithorax, the left hemidiaphragm is usually much commonly involved, and it is much higher, causing herniation of the stomach and the abdominal contents into the hemithorax. And you are seeing actually the left hemidiaphragm, which is interrupted and which is much higher compared to the right hemidiaphragm. This is diaphragmatic injury. So either a stab injury or a RTA patient with this kind of radiograph is given, right? So this is diaphragmatic injury. So identify how to, eventration is a congenital problem. There is a defective formation of the diaphragm, right? Just a hump that is seen, right? This is diaphragmatic eventration. No history of trauma like that in case of diaphragmatic eventration. But once you have a injury given clearly, right, and you see the left hemithorax much higher, the better answer would be a diaphragmatic injury there. Usually the left hemidiaphragm will be much higher level. This is all the different parts that you have, right? So congenital diaphragmatic hernia, Morgagni's will be on the right side, CDH will be on the 𝗏𝗏𝗃 hernia, congenital diaphragmatic hernia, 𝗏𝗏𝗃 will be on the left side. Eventration is a contour defect of the diaphragm, as a congenital anomaly where the diaphragm is not properly formed, right? No history of trauma. If history of trauma is there, stab injury or stuff, think of diaphragmatic injury. Usually involves the left hemidiaphragm. Next thing, eighth one. Try to answer this. Eighth one, guys. A child with acute lymphoblastic leukemia has undergone prophylactic craniospinal irradiation while waiting for bone marrow transplantation. Which of the following will be least affected by radiation exposure? Least affected by radiation exposure. Or which is the most radio resistant? Least affected means what? Most radio resistant. Right? So this is CNS. Remember, the most radio resistant is your CNS. And the most radiosensitive. What is the most radiosensitive tissue or most affected? Will be your bone marrow. Bone marrow is most radiosensitive, and neurons are the most radioresistant tissue in the body. So let us quickly revise most radiosensitive and most radioresistant tissues. For this, we have to understand a law called as law of Burgoni. What it says is undifferentiated cells with high mitotic activity. These are radiosensitive, like your bone marrow, like your gonads. These are radiosensitive. They are undifferentiated cells, stem cells, totipotent cells, right? A lot of mitotic activity is possible. So all of these are radiosensitive. Whereas well-differentiated or quiescent cells, or cells with low mitotic activity, these are radioresistant, like the CNS, like the stratified epithelium of the vagina. All of these are your resistant tissue. The CNS is the most resistant tissue. The vagina is a resistant tissue, right? All of these are resistant tissues in the body. Lymphocyte is a radiosensitive blood cell. lymphocyte has a large nucleus and it will be easily damaged. Okay, the DNA damage will be easy when you give radiation. So lymphocytes are radiosensitive. So all the lymphomas, multiple myeloma, which is B lymphocyte, plasma cell in origin, right, and seminomas, which are having lymphocytic infiltration, all of these are radiosensitive. Lymphocytes are most radiosensitive blood cells. Platelets, they don't have much of DNA. It's a cytoplasmic extravasation of megakaryocytes. So these are the most radio-resistant blood cells. They don't have any DNA or nucleus inside. So radiation will not cause DNA damage here. So they are the most radio-resistant blood cell. So most radiosensitive blood cell is lymphocyte. Most radio-resistant blood cell are your platelets. In the eye, lens is the most radiosensitive. You develop cataracts, right? Especially when you are having a lot of radiation exposure. So important to wear UV protective goggles, right? When you are going for exposure to the eyes, you use protective goggles there. They are the most radiosensitive tissue. The lens, right, develops early cataracts if otherwise. Sclera is the most radioresistant tissue in the eye. Coming to the cell cycle, remember in the cell cycle, we have G0, G1, S, G2 and M. This is the phase of the cell cycle. S phase is the synthesis phase, which causes DNA synthesis to occur. So whenever there is DNA synthesis, in the late stage, there is an enzyme called DNA polymerase. The DNA polymerase does proofreading. So if any DNA damage has occurred, it will come and repair that area. The DNA polymerase will come and repair that area. So the late S phase, where DNA polymerase is acting. So even though you give radiation, you cause DNA damage, the DNA polymerase will rectify it. So the cell will not die. So the late S phase is the most radio-resistant phase of the cell cycle. Whereas G2M phase, this has P53 checkpoint, which is under the control of P53. So any damaged DNA here will made to undergo apoptosis by P53. So you give radiotherapy here, you cause DNA damage, P53 will make it undergo apoptosis. So G2M checkpoint is the most radiosensitive phase of the cell cycle. So don't get confused. Most radiosensitive phase of the cell cycle, cells will die easily when you give radiation at G2M phase. Most radioresistant phase of the cell cycle is the late S phase. Even though you are giving radiotherapy, even though you are giving radiation, you are causing DNA damage, the DNA polymerase is rectifying the damage, the cell will not die at the most radioresistant phase of the cell cycle. So these are some important lists that you need to learn. Late S phase has already been asked, right? You should be careful with that. Last FMGE exam, they asked you most radioresistant phase of the cell cycle. Late S phase, the most resistant phase. Is this table clear, all of you? So once this table is clear, let's also learn what are radiosensitive tumors and radioresistant tumors. The mnemonic that we use here is Wilms, right? Wilms tumor, 𝗬𝗃 sarcoma, lymphoma, multiple myeloma, seminoma. Analogous to seminoma in the ovaries is dysgerminoma, right? And all of these have lymphocytes, right? Lymphoma, multiple myeloma is the plasma cell, B lymphocyte in origin, seminomas, dysgerminoma, they are lymphocytic infiltration. So all of these are there. 𝗬𝗃 sarcoma is the most radiosensitive bone tumor. Wilms tumor, that is nephroblastoma, undifferentiated tissues. Just now we learned law of Burgoni, right? Law of Burgoni, blastema tissue, undifferentiated tissue, right? They will be what? Radiosensitive, right? Undifferentiated tissue will be radiosensitive. So all of these are radiosensitive tumor. Remember the mnemonic? Wilms tumor, 𝗬𝗃s, lymphoma, multiple myeloma, seminoma. Radioresistant tumors is HOMP. What is HOMP? Hepatoma or hepatocellular carcinoma, osteosarcoma, melanoma and pancreatic cancer. So remember, osteosarcoma is a resistant bone tumor. Resistant bone tumor is osteosarcoma. Sensitive bone tumor is 𝗬𝗃 sarcoma, right? Osteosarcoma is a radioresistant tumor, Melanoma, they are neural crest in origin, right? Melanocytes are neural crest in origin. CNS is again radio-resistant. So CNS is radio-resistant. Melanocytes are neural crest in origin. So even though the mnemonic has M, don't get confused. Multiple myeloma is plasma cell, B lymphocyte. Melanoma is neural crest in origin. Melanocytes are neural crest, CNS, radio-resistant. So don't confuse which is the M that you are having. So Wilms and HOMP, right? I hope this is clear. Is this fine, all of you? Can we go to the next one? Okay. Look at here. The linear accelerator produces. Remember, linear accelerator produces X-rays. Linear accelerator, that is called as LINAC, produces X-rays and electron beam. So you need to get electron beam to produce X-rays, right? So electrons will go and strike the target of the anode to produce X-rays. So both electrons and X-rays are produced by linear accelerator, that is LINAC. Gamma rays are produced by radionuclides like cobalt-60, technetium-99m. Right? They produce gamma rays. Positrons, they are produced by positron emitters like 18-fluorine, 18-FDG, right? 18-fluorine, like that. Proton also, right? This is both positron and protons. These are produced by a particle accelerator called cyclotron. So to produce these radionuclides like 18-fluorine, right? Positron emitters like 18-fluorine, we need a particle accelerator called as cyclotron. So cyclotron produces both positrons and protons. So proton beam, and it also produces positron emitters, right, like 18-fluorine. So this is about the different components that are used in your radiotherapy. The LINAC is producing X-rays. Linear accelerator is LINAC. It produces X-rays. Gamma rays are produced by cobalt-60 and technetium-99m. Positrons and protons, these are produced by a particle accelerator called as cyclotron. Next. Can you answer this? Which of the following isotope is used in systemic radiotherapy? Can you answer this, guys? Which of the following is used in systemic radiotherapy? Fastly. We are at the 10th one. We'll try to finish it by maximum another half an hour, but you have to be quick. Which of the following isotope is used in systemic radiotherapy? Remember, iodine 123 is not for radiotherapy. It is for radioactive iodine uptake studies or functional scans of the thyroid. Okay, so for thyroid scintigraphy we use this. This is not for therapy. Iodine 125, this is for low dose rate brachytherapy. You put it inside the prostate gland for prostate cancers. Cobalt-60, this is for external beam radiotherapy or teletherapy. Right? So the most common isotope used in external beam radiotherapy or teletherapy is cobalt-60. Strontium-89 is a systemic radioisotope used for bone metastasis. Right? So when you talk about systemic radiotherapy, remember three isotopes. Iodine 131 for thyroid cancers, thyroid metastasis. It is 131, not 123 or 125. 125 is for brachytherapy. 123 is for radioactive iodine uptake studies, functional scans of the thyroid. 131 is for systemic radiotherapy. Strontium-89 and samarium 153. These are for bone metastasis. These are bone mets. We also have phosphorus-32. This is for 𝗏𝗏𝗴𝗍𝗔. So these are the three isotopes that I want you to learn, right, for systemic radiotherapy. Systemic radiotherapy, iodine 131 for thyroid cancer, strontium-89 and samarium for bone metastasis, phosphorus-32 for 𝗏𝗏𝗴𝗍𝗔. So strontium-89 is the correct answer here. Let's see if we can identify this structure. Identify the mark structure on this image. This is a CT scan image and you're having an orange arrow pointing to a structure. Is asking you what is the structure here. Can you answer this? What is the structure? The arrow is pointing towards the left. So always remember, this is the right side, this is the left side, right? So this is the anterior part of the image, this is the posterior part of the image. So the image is pointing, the arrow is pointing towards the left lentiform nucleus. So this is the caudate nucleus on abutting the frontal horn of lateral ventricle. On either side of the third ventricle is thalamus. And this is the lentiform nucleus. These are your lentiform nucleus. And in the lentiform nucleus, you have two parts, outer putamen, inner globus pallidus. So in the lentiform nucleus, we have two parts. The outer part is putamen, inner part is globus pallidus. So outer putamen, inner globus pallidus. So this is your structures of the basal ganglia. Let's come to the next one. Can you remember this sign? Eye of tiger appearance on MRI. Eye of tiger appearance, a fancy term that we use, eye of tiger appearance. Eye of tiger appearance, very good. Eye of tiger appearance is Haloverden-Spartz disease. Haloverden-Spartz disease, also called as pecan pantothenate pantothenate kinase associated neurodegeneration. So this will have iron deposition in the globus pallidus. So because the iron in the globus pallidus, that iron is dark, it gives that black area like the eye of the tiger. So the eye of tiger appearance on MRI is feature of Ҳәллөверден-Spatz disease, also called as PKAN, pantothenate kinase associated neurodegeneration. CJD, which is a prion disease, will have cortical ribbonning. It will have cortical ribbonning. So the gyral hyperintensities, the gyri will be white. The gyri will be white. So that is called as cortical ribbonning. Multi-system atrophy type C, MSA type C. This has hot cross bun sign. Hot cross bun sign on MRI. So if you see the pons, you see a cross-like area there. Hot cross bun sign of pons is MSA type C. MSA type C. Multi-system atrophy. Multi-system atrophy type C. And what is seen in Wilson's disease? Wilson's disease, we all know, will have panda sign, right? So panda sign is Wilson's disease. So remember these important signs. Ҳәллөверден-Spatz disease, eye of tiger appearance. CJD will have cortical ribbonning. You can remember C for C. Cortical ribbonning is feature of CJD. Multi-system atrophy type C will have hot cross bun sign, and Wilson's disease will have panda sign. Look at this question. An elderly hypertensive patient on treatment for his dementia complains of clumsiness in his right hand and for last 2 weeks, and numbness and in the right face and right upper limb. A CT scan image is obtained. What is the likely abnormality? So the patient has problem on the right side, right? And the image is showing a hypodense area involving the left thalamus. Okay, so in the left thalamus, just now we learned the anatomy. So these are the thalamus. On the left thalamus, you are seeing a black area. This is a small infarct called as lacunar infarct. So remember, these are lacunar infarcts. These occur with lipohyalinosis of lenticulostriate branches. Lenticulostriate branches. So the small hypodense areas that you see on the image, this is nothing but lacunar infarctions. Lacunar infarctions. So these are lacunar infarcts. What is this marked structure that is given here? Can you identify what is the marked structure on this image? Is it medulla, pons, midbrain, or spinal cord? What do you think is this structure that is shown here? Very good, Shanavaz, Gigi, Shirina, right? So this is a correct answer. This is your midbrain. So remember, midbrain will have the crus cerebri, the interpeduncular fossa. You'll have interpeduncular fossa. You'll have the crus cerebri. These are the crus cerebri, right? Now, how to differentiate midbrain from pons is important. So let us look at the anatomy once again. Let us just identify the anatomy. So this is the genu of corpus callosum, the white matter joining the two frontal lobes. This is the splenium, the white matter joining the two occipital lobes. This is the splenium, this is the genu. These are the columns of fornix. These are the columns of the fornix. This is how you have, this is the falx cerebri, the fold of dura separating the two cerebral hemispheres. And the basal ganglia structure we understood: caudate nucleus, thalamus, the putamen, and globus pallidus, the lentiform nucleus, right? So the lentiform nucleus having putamen and globus pallidus. This is the pineal gland, just posterior to third ventricle. This area is the third ventricle, just posterior to third ventricle, pineal gland. This is the occipital horn of lateral ventricle. This is choroid plexus. Choroid plexus. So this is how we have the different basal ganglia structures: caudate, thalamus, putamen, and globus pallidus. We also saw the pineal gland is located posterior to third ventricle. The choroid plexus are located within the occipital horn of lateral ventricle. Look at this image. What is this structure? Is it midbrain, pons, or medulla? To identify the structure, you have to go for this enhancing vessel here. This is your basilar artery. Once you identify the basilar artery, this structure that you are seeing posteriorly is the pons. So to differentiate midbrain from pons, the important anatomical landmark is to identify the basilar artery. If you identify the basilar artery, that structure is pons. Please remember this. So anterior to pons, this is prepontine cistern. The CSF space is called prepontine cistern. Posterior to pons, this is fourth ventricle. So which is pons and which is midbrain? So So pons will have basilar artery anteriorly. The important landmark to differentiate midbrain from pons is basilar artery. Identify the basilar artery and you'll be easily telling that area is pons. Next thing. Next structure, guys. Next question. Lemon sign and banana sign on antenatal scan. Can you identify where do you see lemon sign and banana sign? Lemon sign and banana sign on antenatal scan. Very good. Very good, Mohit. That's right. This is feature of Chiari malformation. Chiari malformation. Chiari malformation and the spina bifida. They show you this lemon sign and banana sign. Lemon sign is bossing of frontal bone bulging. Okay, there is anterior bossing of frontal bone. Banana sign is wrapping of cerebellum around the brainstem. This is banana sign and lemon sign. So the anterior bossing of the frontal bone is called as lemon sign, and the wrapping of the cerebellum around the brainstem, this is called as banana sign. So banana sign and lemon sign, these are features of Chiari malformation. The molar pregnancy will have snowstorm appearance on antenatal scan. Some important things in Turner syndrome. Remember, you will see some classic cardiovascular manifestations. You see bicuspid aortic wall, and preductal coarctation of aorta. This is with Turner syndrome. Posterior urethral wall will show you keyhole appearance. Right? So keyhole appearance on antenatal scan, that is posterior urethral wall. So when you have the posterior urethral wall, that shows the keyhole appearance of the bladder and the posterior urethra. So keyhole appearance is feature of posterior urethral wall. Right? Classically in a male fetus, right? You see this keyhole appearance on antenatal scan. This is posterior urethral wall. So these are important signs that you want you to learn. Right? Next thing. Okay. Let's look at the next one. 30-year-old male with sudden onset of high fever, headache, confusion, seizures. MRI shows hyperintensities in temporal lobes. What is the probable diagnosis? Remember, the most important, lobe involved, or the most common lobe involved in herpes and encephalitis is your temporal lobe. So if you're having temporal lobe involvement in a fever patient, think of herpes simplex encephalitis. Okay, so herpes encephalitis produces temporal lobe involvement. So it involves the bilateral temporal lobes. Tuberculous meningitis, this produces basal exudates. So when you see this word basal exudates, please mark it as tuberculous meningitis. Tuberculous meningitis produces basal exudates, hydrocephalus, infarcts. The triad of TB meningitis: basal exudates, hydrocephalus, and infarcts. Remember, basal exudates, mark it as tuberculosis. Neurocystic sarcosis, based on the stage you are in. A vesicular stage will produce cyst with central scolex. This is seen in vesicular stage. And you also have a starry sky appearance, right? Starry sky appearance on CT. This is feature of calcific stage of neurocystic sarcosis. Calcific stage of neurocystic. Toxoplasmosis produces ring enhancing lesions, especially in the basal ganglia. Ring enhancing lesion in the basal ganglia in AIDS patients. Right, so ring enhancing lesion in AIDS patients is toxoplasmosis. So here, because there is temporal lobe involvement, the answer should be herpes encephalitis. Look at this question here. A 45-year-old female with visual symptoms undergoes MRI, and you are seeing coronal and sagittal image. So this is the coronal section that is given to you, and this is a sagittal section that is given to you, and he is asking you what is the diagnosis. Can you answer this? A 45-year-old female with visual symptoms undergoes MRI. The coronal and sagittal images are obtained. What do you think is this? Can you quickly answer this? Can you look at this and quickly answer this? Look at the image carefully. You are seeing a lesion in the region of the pituitary gland, and it is showing a figure of 8 appearance at the cella. It's purely solid, no calcification, no cystic areas, purely solid, right? Showing this figure of 8 appearance at the cella. This is pituitary macroadenoma. And pituitary macroadenoma, it will compress the optic chiasma. Pituitary macroadenomas, they compress optic chiasma. And when you have optic chiasma compression, what is the visual field defect you get? Bitemporal heteronymous. hemianopia. So if they give you the visual field defect, they'll be like this, right? So bitemporal heteronymous, right? Hemianopia. So there will be visual field defects. This is the craniopharyngioma. Remember two C's: calcifications and cystic area, solid cystic mass in the cella. So you see calcification in cystic area. Most common calcifying brain tumor is craniopharyngioma, or solid cystic mass at the cella is craniopharyngioma. So you see calcification, you see solid cystic lesion, that is craniopharyngioma. Pituitary macroadenoma shows you a figure of 8 appearance at the cella. Right? And meningioma, remember two signs: dural tail sign and mother-in-law sign. Intense contrast enhancement, which is early to come and late to go. Early enhancement and delayed washout, like mother-in-law, early to come and late to go. Early enhancement and delayed washout. That contrast enhancement pattern is called mother-in-law sign, feature of meningioma. So mother-in-law sign and dura matter is meningeal layer, right? So dural tail sign and mother-in-law sign, these are features of meningioma. Okay, so just important ones to remember: craniopharyngioma will be a solid cystic lesion at the cella. Craniopharyngioma will be calcifying lesion there, right? Okay, a supracellular calcification. A supracellular calcification is craniopharyngioma. Solid cystic mass at the cella, supracellular calcification is craniopharyngioma. Pituitary macroadenoma will show you a figure of 8 appearance at the cella. And purely solid, no calcification, no cystic areas. Pituitary macroadenomas, these pituitary macroadenomas will have no calcifications, no cystic areas, right? Unlike craniopharyngioma, this will not have calcification or cystic areas. Calcification and cystic areas, 𝗚𝗏𝗃, the craniopharyngioma, solid cystic and calcification. And mother-in-law sign and dural tail sign is meningioma. Let's come to the next one. Identify this marked structure on the CT head. What is this CT head marked arrow showing you? So you can identify it easily. This is your, what do you think is this? Very good. This is optic nerve, optic nerve. So if the optic nerve shows a fusiform enlargement, so this is the optic nerve, these are the rectus. If the optic nerve shows fusiform enlargement, this is optic glioma. And optic gliomas are more common in NF1. If you see that there is a fusiform enlargement of the inferior rectus and the medial rectus, right? So if you're seeing the medial rectus, this is the lateral rectus, this is the medial rectus. If you're seeing, and this is the optic nerve. If you're seeing fusiform enlargement of the optic nerve, this is optic glioma. If you're seeing fusiform enlargement or Coca-Cola appearance of the extraocular muscle, especially the inferior rectus and medial rectus, inferior rectus more than medial rectus, if you see such fusiform enlargement, this is thyroid ophthalmopathy. Thyroid ophthalmopathy. And if you're seeing diffuse enlargement of the extraocular muscle, no tendon sparing. In case of thyroid ophthalmopathy, the tendon is spared, there is tendon sparing. But if there is diffuse enlargement without any tendon sparing, a diffuse enlargement of the extraocular muscle, this is orbital pseudotumor, orbital pseudotumor. And if you see that around the optic nerve, you see tram track appearance of optic nerve. This is suggestive of optic nerve sheath meningioma. And meningiomas are common with NF2. Remember, 𝗵𝗔. NF2 is 𝗵𝗔. Multiple inherited schwannomas, meningiomas and ependymomas. Schwannoma, meningioma and ependymoma. 𝗵𝗔 lesions. These are common with NF2. So optic gliomas are common in NF1, whereas meningiomas are common with NF2. Optic nerve sheath meningioma produces a tram track appearance of the optic nerve. There will be enhancement on either side of the optic nerve. Is this clear? Fine. Next thing. Look at the next one here. The given skull X-ray. What is the image showing you? Easy one, simple one. I hope you'll all answer this. What is this appearance called? What is this appearance called? This is hair on end or crew cut appearance, right? Hair on end or crew cut appearance. This is thalassemia. What is the shape of the skull in multiple myeloma called? What is the appearance of the skull called? What is the appearance of the skull in multiple myeloma? You have multiple punched out lytic lesions. This is called as raindrop skull, raindrop skull. And what is the appearance in increased ICT? What do you see in increased ICT? Increased ICT will cause sutural diastasis in children. In adults, you will have erosion of dorsum sella. But what is the skull finding that you have? Increased ICT produces silver beaten or copper beaten skull. Copper beaten skull. And what is the finding that you see in Paget's disease? In Paget's disease, what is the finding that you see? Paget's disease, again, it will have different phases, right? You have a lytic phase, you have a mixed phase, you have a sclerotic phase, right? So different phases you have. The lytic phase will produce lucency here called as osteoporosis circumscripta. The mixed phase will produce cotton wool skull. Cotton wool skull. The dense sclerotic phase will produce like a woolen cap, okay, densely sclerotic, that is called as Tam-o-Shanter skull. So these are features of Paget's disease. So osteoporosis circumscripta, cotton wool skull, Tam-o-Shanter sign, all of these are features of Paget's disease. So these are the different skull findings that you have. Please remember, hair on end or crew-cut appearances, thalassemia. Multiple myeloma produces raindrop skull. Increased ICT produces silver beaten or copper beaten skull. Paget's disease can produce cotton wool skull. You also have osteoporosis circumscripta and Tam-o-Shanter sign. Where do you see geographical skull? Where do you see geographical skull? You heard of geographical skull anytime? This is seen in Langerhans cell histiocytosis, that is eosinophilic granuloma. Eosinophilic granuloma, the Langerhans cell histiocytosis that produces geographical skull. Okay. Let's come to the next one. An industrial worker admitted to the hospital after an injury after work with hammer and chisel. A foreign body is suspected to be impacted in his eye. Which of the following investigation would be detrimental or harmful? Harmful. Detrimental means harmful. What is the answer here? Please read the question carefully. Okay, so please be detrimental. Detrimental means what? Harmful. MRI will be harmful. MRI is contraindicated. So what you're dealing here, when you're having a hammer and chisel, what are you dealing with? When you're having a hammer and chisel, you're dealing with intraocular metallic foreign body. Intraocular metallic foreign body. Metallic foreign body. So when you have an intraocular metallic foreign body, because you're working with hammer and chisel and he had a foreign body sensation, you should suspect a metallic foreign body. When you have an intraocular metallic foreign body, remember the investigation of choice is CT. But what is contraindicated? MRI is contraindicated. Obviously, MRI will be contraindicated, metallic, foreign bodies. So MRI is contraindicated. If he asked you which is detrimental, detrimental, the English meaning of detrimental is means which is harmful or which is contraindicated. MRI is contraindicated. Absolute contraindication. MRI is an absolute contraindication for intraocular metallic foreign body. Next. Try this question. What is a skull view obtained in this patient? So they gave you a radiograph and they're asking you what is the skull view. Let me see if you can answer this. Instead of detrimental, they'll ask you, if they want to ask you CT, they'll ask you what is the investigation of choice or what is the preferred investigation to detect the metallic foreign body. Detrimental means harmful. Next. What is the skull view obtained in this patient? Is it Colville view, Townes view, Waters view, Perry's view? So first, whenever you're given a skull radiograph, identify the maxillary antrum. Then identify the petrous ridge. The petrous ridge. If the petrous ridge is below the maxillary antrum, you are seeing the maxillary antrum clearly. The petrous ridge is below the maxillary antrum, and you're having a closed mouth. You can see the two teeth closer. Okay, the closed mouth is there. So occipitomental view or occipitomental view with closed mouth. This is Waters view. Perry's view is same occipitomental with open mouth. Open. Colville view is occipitofrontal. Occipitofrontal. So in Colville view, if you see the maxillary antrum and the petrous ridge, if you see the maxillary antrum and the petrous ridge, the petrous ridge will be overlapping the maxillary antrum. It will be below the orbit. Below the orbit, overlapping the maxillary antrum. That is how the Colville view will be. In Townes view, you have a AP view of skull with 30-degree angulation. Right? So anterior-posterior view of the skull with 30-degree angle is called as Townes view. So if you see the maxillary antrum and the petrous ridge is below the maxillary antrum, this is occipitomental view, the Waters view. If the petrous ridge is overlapping the maxillary antrum, that is 𝗙𝗪 view. So look at the maxillary antrum, look at the petrous ridge and identify which is Waters view and which is 𝗙𝗪 view. 𝗙𝗪 view we all know is for frontal sinus, and the Waters view we all know Waters view is done for maxillary and also for orbital floor fractures. We go for Waters view. So maxillary sinusitis and orbital floor fractures is by Waters view, frontal sinus is 𝗙𝗪 view, right? Okay. Try to answer this one, guys. Try to answer this. A 40-year-old male patient on long-term steroid therapy for systemic disease presents with recent onset of severe pain in the right hip. Imaging modality of choice for this problem is. So you're dealing with a patient with long-term steroid use and he has developed hip pain. So what are you thinking of? Obviously, you're thinking of avascular necrosis, long-term steroid therapy, right? Hip pain, you're thinking of avascular necrosis. So basically, he's asking imaging modality of choice for this patient. So remember, MRI is the investigation of choice for avascular necrosis, right? Avascular necrosis. MRI is also the investigation of choice for avascular necrosis in young. What do you call that? 𝗵𝗵𝗺𝗃 disease, 𝗵𝗵𝗺𝗃. It is also the investigation of choice for ankylosing spondylitis. It is also the investigation of choice for acute osteomyelitis. Remember this 4 A's, right? Remember this 4 A's for which the investigation of choice is MRI. And also it is for stress fracture, march fracture or stress fracture. It is MRI. So investigation of choice for all these conditions is MRI. So avascular necrosis in young patients called as 𝗵𝗺𝗃 disease, ankylosing spondylitis, low backache, right, sacroiliitis that you have, right? So that is ankylosing spondylitis, acute osteomyelitis, stress fracture or march fracture. Investigation of choice is MRI. Identify the next one here. A 65-year-old hypertensive patient on irregular medication has headache and BP is 220/110. CT scan head is shown below. What is the diagnosis? So you can see there is a hyperdense collection in the right putamen. So this is a hypertensive bleed. The most common site of hypertensive bleed is putamen. The most common site is putamen. So hypertensive bleed will occur at the putamen. So this is hemorrhagic stroke, the putamenal bleed or intraparenchymal bleed that you're seeing in this patient with uncontrolled hypertension. Next. What is this image showing you? LCCT image of the patient showing severe onset, acute onset of severe headache. And what do you see here? So this is a non-contrast CT. Look at the question. It's a non-contrast CT. It's having severe headache and the image is showing these white areas involving the sylvian fissure, the basal cisterns, the interhemispheric area, right? The basal cisterns, interhemispheric area, sulcal spaces, sylvian fissure, all of these areas are showing this hyperdensity. All of this is suggestive of acute subarachnoid hemorrhage, acute subarachnoid hemorrhage. So this is acute subarachnoid hemorrhage, okay? So severe worst headache of his life, thunderclap headache, right? Hyperdensity in sylvian fissure, sulcal spaces, Next one, a patient with RTA is unconscious and the CT scan image does not show any finding except for petechial hemorrhages. What is the probable diagnosis? 25th. 25th, what do you think is this? Very good. So you're having an RTA patient who is unconscious. CT scan is not showing any findings. CT scan is normal or may show petechial hemorrhages, just few petechial hemorrhages. This is classic diffuse axonal injury. Remember, CT scan can be normal or shows petechial hemorrhage. What is the investigation of choice? The investigation of choice for diffuse axonal injury is also MRI. Diffuse axonal injury is MRI, right? And pneumocephalus, what is a sign that you see in tension pneumocephalus? When you have trauma to the skull and you have pneumocephalus, what is a sign that you see in pneumocephalus? You see a 𝗵𝗃𝗃𝗃 sign when there is a tension pneumocephalus. 𝗵𝗃𝗃𝗃 sign is tension pneumocephalus. It will be like this, right? So like a mountain. In trauma patients, the air will come anterior to the frontal lobes, anterior to the frontal lobes. This is called as 𝗵𝗃𝗃𝗃 sign, 𝗵𝗃𝗃𝗃 sign. This is classic of tension pneumocephalus, tension pneumocephalus, right? Now, let's come to the next one, 26th. Identify a 20-year-old female presents with recurrent UTI. Identify the condition based on the given IVP image. Is it pelvic kidney, horseshoe kidney, duplex kidney, or crossed ectopic kidney? Right, answer this. What is this? Now please remember, in duplex kidney we have three kidneys. There is a normal kidney on the normal side, and there is duplication on the other side. This is crossed fused ectopic. The kidney has crossed the midline and fused with the other kidney. So this is classic crossed fused ectopic, not a duplex kidney. In duplex kidney we have three kidneys. There will be a normal kidney on the normal side and duplication on the other side. Whereas this is only two kidneys on one side. The kidney has crossed the vertebra, crossed the midline, and fused with the other kidney. So cross the midline, cross the vertebra, and fused with the other kidney. You are having two kidneys in the patient. This is crossed fused ectopic. So do not confuse between duplication system and crossed fused ectopic. Duplication system will have three kidneys, whereas a crossed fused ectopic will be both the kidneys on one side of the vertebra. Right? Is that okay, all of you? Next thing. This, I hope you will answer this correctly. What is the thickness of lead apron? What is the thickness of lead apron used in radiation protection? What is the thickness of lead apron used in radiation protection? Very good. I see everybody answering this correctly. This is point. The thickness of lead apron, remember the most common used thickness for radiation protection is 0.5 mm. That should be your answer. 0.5 mm of lead equivalent is used. But if they ask you minimum thickness required for radiation protection, then 0.25. Remember 0.5, this is your previous P by Q. Remember this 0.5 mm. The thickness of lead apron for radiation protection is what? 0.5 mm. What is Gray a unit of? Let's look at the next one. Gray is a unit of radioactivity, radiation exposure, absorbed dose, or dose equivalent. Gray is a unit of. Remember, what are the units of radioactivity? Radioactivity, the conventional unit, we have conventional units and SI units. The conventional unit of radioactivity is Curie. Madame Curie worked on radioactivity. And the SI unit is Becquerel. Henry Becquerel is the father of radioactivity, right? Father of radioactivity. This is for radioactivity. What is the units for radiation exposure? What are the units for radiation exposure? The conventional unit is Roentgen, the father of radiology, right? So radiation exposure dose is Roentgen. And the SI unit is coulombs per kg, coulombs per kg. Absorbed dose is measured in rad and Gray. So absorbed dose is rad and Gray. So this is absorbed dose. Whereas equivalent dose, this is measured in Rem and Sievert. Rem and Sievert. So remember A, absorbed dose. Rem and Sievert is for equivalent dose. Equivalent dose also uses radiation quality factor, RQF, right? RQF. So Rem and Sievert is for equivalent and effective dose, and radiation quality factor is used in equivalent dose. Okay, so there is one more thing called effective dose also. Effective dose. Effective dose is also Rem and Sievert. But effective dose uses tissue weighting factor. Tissue weighting factor. Tissue weighting factor. So Rem and Sievert, both of them having E, right? Both of them are for equivalent and effective dose. What is the difference? One uses radiation quality factor, one uses tissue weighting factor. So tissue weighting factor is used in effective dose, radiation quality factor is used in equivalent dose, These are for radiation units, Which of the following uses piezoelectric crystals? Piezoelectric crystals. Easy one, 29th. Which of the following uses piezoelectric crystal? 29th. Very good. So ultrasound uses piezoelectric effect. Right? And can I ask you, what is this piezoelectric crystal made up of? This is made up of lead zirconate titanate. And what is CT scan based on? This is based on linear attenuation of X-rays. What is MRI based on? This is based on gyromagnetic properties of H+ ions. and uses nuclear magnetic resonance. And what is TLD batch used for? It is used for radiation exposure. What is a radiation exposure in occupational workers? And what is this TLD batch made up of? It is made up of lithium fluoride or calcium sulfate dysprosium. Okay, so the TLD batch is made up of lithium fluoride or calcium sulfate dysprosium. It is used to measure the radiation exposure in your occupational workers, right? Lastly, what is the most sensitive imaging modality for ureteric stone in patient with acute renal colic? So what is the most sensitive investigation that you would like to do for ureteric stone in acute renal colic? What is the thing that you would like to go for? Would you go for MRI, ultrasound, non-contrast CT or contrast enhanced CT scan? What is the investigation for ureteric stone in renal colic? Or basically for ureteric calculi, what is the investigation of choice? So stones, for looking at ureteric stones, you need not give contrast. It will be seen on non-contrast CT, so NCCT. Remember, NCCT is the investigation of choice for head trauma, for acute subarachnoid hemorrhage, for stroke patients to differentiate hemorrhagic stroke from ischemic stroke. Hemorrhagic stroke will be white, hyperdense. Hyperdense means what? White. Ischemic stroke will be hypodense, black or normal, right? Even normal CT scan in a patient of hemiplegia should be considered as ischemic stroke. So these three things, remember, for head trauma, for acute subarachnoid hemorrhage and for stroke patients, we use non-contrast CT. Non-contrast CT is also useful in coronary calcifications, the Augustin scoring that you do for coronary calcification, and also for ureteric calculi. So these are some important indications for non-contrast CT. Contrast enhanced CT scan should be used for lung cancers, small bowel tumors, for tumors, RCC, right? So you go for contrast enhanced CT scan. Contrast enhanced CT scan is also used for infective conditions like renal tuberculosis, right? Appendicitis, inflammatory conditions like pancreatitis, diverticulitis, all these itis, where you have vasodilation, you'll have a lot of contrast coming into these areas. And also remember, CECT is the investigation used in abdominal trauma to know the organ of injury. In abdominal trauma, to know organ of injury. So for this, we need to go for contrast. So wherever contrast blush is coming, that is organ that is injured. Contrast blush from the liver is hepatic injury. Contrast blush from the spleen is splenic injury. So in abdominal trauma, we go for CECT. For head trauma, we go for non-contrast CT, right? So important to remember the indications of non-contrast CT and CECT. Last one before we end. Nephrogenic systemic fibrosis occurs as a side effect of which one? Nephrogenic systemic fibrosis develops as a side effect of. Very good. So NSF is a problem that occurs with gadolinium. Okay, gadolinium. Iohexol or iodinated contrast. They are known to produce contrast-induced nephropathy. And contrast-induced nephropathy is increase in serum creatinine by more than 0.5 milligram per deciliter or more than 25% from baseline within 48 to 72 hours of IV contrast, right? Barium, this is contraindicated in bowel perforation because of risk of chemical peritonitis. Sulfur hexafluoride, this is called SonoView. It's an ultrasound contrast. These ultrasound contrasts are microbubbles of gases. And because these are gases of sulfur hexafluoride, microbubbles of sulfur hexafluoride, these gases are excreted by lungs, not by the kidney. So these ultrasound contrast sono-view, that is sulfur hexafluoride, is safe in chronic kidney disease. Safe in chronic kidney disease. Or you don't need to measure any serum creatinine levels pre-contrast. So pre-contrast RFT is not required. Pre-contrast RFT is not required in ultrasound contrast agent, that is sulfur hexafluoride. I hope this quick session was productive for all of you. So we are planning to do similar sessions with high yield MCQs, which will help you have a quick revision of your concepts that you have already learned in your regular sessions with us. And I hope you find these sessions productive and useful for your exam. And stay consistent. The last few days, just think about a single day. Don't keep on worrying about your exam or be anxious about your exam. See that you control your 24 hours, right? So plan properly, win each day, and your exam day will also be taken care of. So don't panic. It's about your mental game also. Take each day at a time, right? It's not about 300. You can forget few questions, you can do mistakes in few questions. You just have to get your 150. It is not about knowing everything. You don't have to worry and panic unnecessarily for that. Just focus on being smart, trying to get your 150 and giving your full focus and attention in your revisions, right? So do not think about the exam day. Concentrate on winning each day, right? It is not about 300. You're free to do mistakes, you're free to forget questions, you're free to do some things. You still will have your enough knowledge to see that you get your 150 in your exam day, right? Take care and thank you so much.